Hello, doctors. Hello, everyone, and welcome to our SKINCEUTICALS webinar. I'm very excited to be welcoming you all today. Although we would have loved to be there in person with you in Kuwait, all of us in one room. We're happy to amend with the situation and be joining you all virtually. Hopefully, when the situation improves, we'll all be able to gather together physically. Allow me to just introduce myself. My name is Rawan Mahmoud. I'm the Regional Medical Business Development Manager for SKINCEUTICALS here in the Gulf. For those of you who I haven't met in person on my last visit to Kuwait, I'm happy to e-meet you all today. And hopefully once travel opens, I'll be able to come and physically visit you all. It is my absolute pleasure to be introducing our esteemed speaker today, Professor Ashraf Badawi. I believe that in Kuwait and in the GCC, Professor Ashraf needs no introduction. He's one of the most well-known dermatologists in our region, especially focused on laser therapies, where he's trained over 3,500 dermatologists over the span of his career. He has over 21 publications to his name. And of course, he's the president of the European Society for Cosmetic and Aesthetic Dermatology, as well as the Society for Laser Dermatologies. So it's really our pleasure to be having him on our discussion time. Please feel free to type in any of your questions in the chat box during the lecture that we can address at the end, or at the very just unmute your mic and have direct contact. Afterwards, also we'll be having a short presentation on the solutions that SKINCEUTICALS can provide for your hyperpigmentation patients post-laser treatments. So thank you again, Dr. Ashraf, for being with us, and I'll leave the virtual stage to you.
Thank you, Dr. Rawan. It's a great pleasure to be here today with all of you. And although we are in Canada and it's around 0 Celsius, but inside the home it is warm enough. So I'm enjoying the time, and hopefully all of you are safe. And next time, hopefully, we are going to be meeting face to face when this COVID era is over. So let's start the talk. And as you mentioned, we are going to have the questions at the end. My topic of today is laser treatment of pigmented lesions and tattoos. And I think we all agree that the safe and effective laser treatment of patients with benign pigmented lesions and tattoos, especially in darker skin types, the skin types we have in the Middle East, are considered a challenge to the laser surgeon and is becoming more frequently encountered as the patient population continues to increase. Why this is a challenge? Because we have so many difficult situations we are facing when we are treating pigmented lesions with lasers. One of them is resistance. So some of the pigmented lesions we are trying to treat are very resistant for the treatment. They require many sessions in order to show even slight improvement. Recurrence. Some of the lesions are having recurrence. For example, the cafe au lait macules, they respond nicely initially, but the recurrence rate within a year is almost 95%. Complications. Some of the lesions might get worse and become darker after laser treatment, like, for example, the PIH, post-inflammatory hyperpigmentation, or melasma. In many cases, patients, once they hear the word laser, they think that we are having a magical stick where we are going to treat the lesion and it's going to disappear within a session, which is never the case, and usually high or unrealistic patient expectations will lead to failure. And then those devices which target pigmentation and tattoos are having limited indications, and this is going to be associated with low profitability. And those are the main challenges we are facing in treating pigmented lesions and tattoos. As we can see in this photo, there are so many benign pigmented lesions which are either present in a critical anatomical location, like around the eye or around the nose or in the face in general, or sometimes we are not quite sure how this is going to respond, or it might be part of a bigger syndrome like the giant pigmented hairy nevus, where this is only one part and there is a much larger part on another part of the body. So should we treat one lesion and leave the others, or what? So all those are challenges where we need to think well, and in many cases we might need to work within a team in order to come up with the best treatment scenario and the best management for those lesions. The benign pigmented lesions can be epidermal, like the lentigens, like this one, solar lentigens in younger age and senile lentigens in older age. We might have freckles, cafe au lait macules, nevus spilus, and seborrheic keratosis. All those are epidermal lesions and they are not quite difficult to treat. However, we need to select the right tools in order to manage the condition successfully. We have then the dermal lesions like nevus of Otta, the picture we have on both sides of the slide, which is a dermal pigmentation. It's bluish hue and sometimes it involves the sclera as well. And if the same nevus comes on the shoulder, it is called nevus of Ito and blue nevi or blue nevus. Those are dermal pigmented lesions and they need definitely the Q-switched lasers and the picosecond lasers to be treated. In the old days of the laser, they classically were treated by the carbon dioxide laser, but it left scars in 100% of the cases treated because this is dermal pigmentation. By the time we ablate the pigmented lesions, we are already crossing the dermo-epidermal junction, and this will definitely end up by scarring. So it is an obsolete way of treating those kinds of pigmented lesions. Then we have the most common type of pigmentation, which is the dermo-epidermal lesions, like melasma, like post-inflammatory hyperpigmentation, like Becker's nevus and compound nevi, and all those are dermo-epidermal lesions where partially it is in the epidermis, partially in the dermis, and treating those lesions with lasers is a challenge. Actually, with laser and without laser, it is a challenge, and we have to know how to deal with it in order to avoid the complications and darkening of the pigmented lesions. Then at the end we have the tattoos, which are considered some sort of skin pigmentation, exogenous pigmentation. They might be of different colors, the black, blue, black, green, and red. And now with the more advanced colors of the tattoos, we have even more colors. It might be decorative, like those tattoos which are on the shoulders of the young people. The traumatic tattoo, which can happen after gunshots or after car accidents. Cosmetic tattoos like the eyebrow tattoo and the lip line tattoo. And finally, medical tattoos, and those are the tattoos which are used in order to improve the appearance of patients who are having vitiligo when they tattoo them with a skin color tattoo, or the tattoos used for marking the radiotherapy sites for patients who are having cancer and undergoing radiotherapy. So those are the medical tattoos. And then the tattoos might be professional, which are multicolor, and amateur. The professional tattoos are more difficult to treat than the amateur tattoos. We have this important Kirby Daisy tattoo removal scale, which can give us a hint about how many sessions might be required. So with this, we have 6 parameters which we need to grade. The skin type from 1 to 6, and the darker the skin, the more points we give. The location, if it is in the head and neck or face, or in the upper trunk or shoulder, in the lower trunk and upper leg, this is 3 points, lower arm or leg, and the rest, the hand, the ankle, or the foot, and this is 5 points. This is actually evaluating the lymphatic drainage, because as we are going to see in few minutes, lymphatic drainage plays a very important role in clearing the pigments after the laser tattoo removal or the benign pigmented lesion removal. because we depend on the lymphatic drainage. So the areas which are having poor lymphatic drainage will have higher number of points. The areas which are having better lymphatic drainage are having less number of points. Of course, then the amount of ink, if the amount is small, if it is immature, then it's 1 point. If we have significant amount of ink, then it is the highest, which is 4 points. Then the layering, which means if the tattoo is present in one layer or in multi-layers, then we have a grading for that. If there is scarring and tissue changes, if there is no scar, then 0 points. If we have significant scarring, then it's 5 points. And then the colors, black only 1 point, and if we have multi colors, then it is 4 points. So we can see that when the points are higher, then the expectations of the number of sessions requires are going to be much higher. This is the principle of this Kirby-Daisy tattoo removal scale. It is not a precise one. However, it gives us a hint if this patient can expect 1 or 2 sessions for removing the tattoo and getting significant improvement, or we might need 6 to 8 sessions or even more. Now, the mechanism of action of the lasers to remove tattoos is very important. Not only the tattoos, the pigmentation in general. So we have a collection of ink or collection of melanin, and then we apply a laser pulse. The laser pulse is going to lead to fragmentation of this collection of pigment. And then there is phagocytosis. The phagocytes or the macrophages are going to collect those small fragments. Now, this is very, very important slide because it's going to explain 2 important facts when we come to treating benign pigmented lesions and tattoos with the laser. One of them is that the patient has to understand and expect that the lesion is becoming worse before it improves. Why it becomes worse? Because we have collection of pigmentation, whether it's ink or melanin, and then we throw a bomb. The laser pulse in this case is having very short pulse duration, very high peak power. So this is called photomechanical or photoacoustic effect. It is not thermal effect. This is going to lead to explosion. So it's going to fragment this ink or this melanin into small fragments. When we have this situation, some of the fragments are going to be displaced laterally. Some of the fragments are going to be displaced superficially. So in either cases, the pigmented lesion is going to look worse than before the treatment. So the patient has to understand that things become worse before it improves, and this is a sign of efficacy. So nothing to worry about. It is going; those fragments are going to be engulfed by the macrophages and removed into the lymphatics. The second important fact from this slide is that the spacing between the sessions should be not less than 6 to 8 weeks in order to give the body the time in order to have this internal body mechanism where removal of the fragments from the skin is going to take time. And if we try to treat on shorter intervals, this is going to be associated with post-inflammatory hyperpigmentation risk. So it's really very important to make sure that we are giving the right interval in between the sessions in order to avoid complications. So those are 2 important things. Number 1, the patient has to know that the situation is becoming worse before it improves. Number 2, the interval between the session should not be less than 6 to 8 weeks before we go ahead with the following session. Now, this is solar lentigenese or senile lentigenese. As I said, we can call it either way, depending on the age of the patient. And this is epidermal pigmented lesion, which can be removed easily by many, many things, including chemical peeling, bleaching agents, sunscreens, Q-switched lasers, which are targeting the epidermis. May I ask everyone to mute? May I ask everyone to mute their mic, please? Thank you. So we can see that those epidermal pigmented lesions can be removed within 1 or 2 sessions very easily with the Q-switched lasers, which are targeting the epidermis, like the 532, like the IPL, like the Q-switched alexandrite, or even the short pulse alexandrite. This is café au lait macule, and café au lait macule is epidermal pigmented lesion, which can be again removed by Q-switched lasers, which can target the epidermal pigmentation. However, we have a challenge in this indication where the recurrence within 1 year is going to be seen in more than 95% of cases. So this is very important to be transferred to the patient. The patient expectations are very important. Once the patient knows that they need to come back once a year, maximum twice a year, they are going to be okay with that. But if we don't tell them that the recurrence rate is high and they are under the impression that it is going to be one-time treatment and that's it, they are not going to be satisfied. So it's very important to communicate that with the patient. Now, this is a nevus of Otta, which is taking the lower lid of the patient. It is treated with the Q-switched Nd:YAG lasers, the 1064, the Q-switched Alexandrite or Q-switched Ruby. The Q-switched 1064 is the best among all the lasers because of the deeper penetration and because it's safe on darker skin types. So this is my favorite. However, whenever we are beside the eye, it is really very important to take all the precautions to protect the eye. And if you are treating a lesion inside the orbital margin, it's very important to use the intraocular shield to avoid any ocular damage. And this is an interesting case of a patient who had vitiligo, and the patient is having still some remnants, islands of normal skin. And in this case, we can target those islands of normal pigmented skin with a Q-switched laser. And in this case, I would use both the 532 and the 1064 in order to target both the dermal and the epidermal component of the pigments. And in this case, we can get clearance of the remaining islands of pigmented skin. An alternative to that is to use ablative lasers, which I don't really like because of the associated downtime. And this is the same patient, and we can see how we were able to get rid of the remaining islands of normal skin. And this is a case of a mature tattoo. And we can see that immediately after the laser treatment, we can see the immediate whitening. And this is a very important endpoint, which we would like to see in every single session we are conducting. Two important things I would like to highlight in this slide. The first one is the fact that we need to see this endpoint every session. So if we start with low fluence, because the intensity of the pigment is high, if I use the Q-switched Nd:YAG for this patient, for example, I would start with 4 joule per centimeter square, and I'm going to see this whitening. Next session, when the patient comes after 8 weeks, if I use the same fluence, I'm not going to see this endpoint, I'm not going to see this whitening, and this means that the density of the melanin of the ink decreased and the absorption is becoming less. So at that time, in order to see this endpoint, I have to increase the fluence. Maybe instead of 4, I would use 4.5 or 5, but I have to see this endpoint and this whitening of the tattoo. The other important thing is that we have to let the patient know that this is a temporary action. The tattoo is not gone. It is just immediate whitening of the tissue because of the pyrolysis, the increase in the temperature of the ink to 300 Celsius, so gas bubble formation. And this is going to be temporary, maybe within 15-20 minutes is going to go back. Why I'm saying that? Because many patients saw this immediately after the session and they thought that we get rid of the tattoo already. Once they went home and they found it back, they returned to the clinic claiming that the treatment was not effective. So again, it's really very important to educate the patient about the expectations, what's going to happen, how many sessions are required, what is the required skincare after the laser treatment, and so on. And this is another amateur tattoo where someone had a tattoo on the shoulder, and this is immediately how the tattoo is looking with the immediate whitening, and then within 5 sessions it is almost gone. So we can see the efficacy of the laser treatment in a mature tattoo. This is another type of tattoo with multicolor. So we have red color and then we have green color. So it has been treated. This is immediately after the treatment, and we can see the immediate whitening. and then the treatment goes on. Of course, here we need to use the 532 for the red tattoo, and we need to use the 1064 for the green tattoo. And we can see that after one session, the green tattoo is almost gone, significant improvement. The red tattoo needs further sessions, and after 5 treatments, the tattoo is gone. So we can see very nice efficacy. There is a scar here. It is not due to the laser treatment. Actually, it is the reason why this patient wanted to have a tattoo. The patient wanted to cover the scar with this kind of tattoo, but then after some time he changed his mind and we wanted the tattoo to be removed. So this is not a scar due to the laser treatment, it's a scar due to another trauma, and it is not due to the laser. What about Becker's nevus? Becker's nevus is a compound nevus, so it's partially in the epidermis, partially in the dermis. It is one of the challenging conditions because usually it is large. It is taking a large part of the skin, and if you would like to treat it, it is going to cost the patient a lot because of the number of pulses we are doing and the time consumed to treat the tattoo, the nevus. And moreover, the patient usually is not satisfied because the effect is not homogeneous. Some areas will respond much better than other areas, so we might be left with heterogeneous pigmentation, where some areas are going to be hyperpigmented, some other areas are going to be hypopigmented, and some areas will be responding very well. So that's why I personally try to convince the patient not to treat Becker's nevus. If it's hairy Becker's nevus, then we do hair removal, and sometimes becoming lighter, and the patient will be satisfied. If the patient insists, then we go by segments. So I select a segment, and I tell the patient, we agree with the patient that this is the segment we are going to be treating every single time the patient comes back till we reach the best result, and we tell the patient that this is the best we can achieve. If the patient is satisfied, then we go to another segment of the nevus, and so on. But this is a much better approach than treating the whole nevus every single session, and then the patient is paying a lot. And when the patients are paying a lot, they are having very high expectations. So I don't recommend that at all. Post-inflammatory hyperpigmentation and melasma respond unpredictably to laser treatment, with the lesion darkening, lightening, or not changing at all, and repigmentation is the role. So the PIH and the melasma, we have to be careful because many of the lesions treated with laser will become darker after the treatment. So it is something which we have to be careful with. If the patient insists, then we can do a small test area to see how it is going to respond before treating the whole lesion and charging the patient a lot of money. Upon laser impact, the ink particles fragment, followed by macrophage engulfment and gradual clearing of the tattoo. Eventually, tattoo ink appears in the regional lymph nodes of the tattooed patients, and that's why there is a lot of reservation on treating large tattoos. Number one, the ink particles might go to the lymph nodes in large quantities, and this might lead to foreign body granuloma, and there are few case reports about that. In addition, the carcinogenicity might be there, and there are few reports now about some patients who develop melanoma after laser treatment of professional tattoo. And if we look carefully and deeply into those reports, it is not due to the laser. So the patient did not develop the melanoma due to the laser. However, because of the tattoo, the signs of melanoma were not detected. In many cases, those treatments are not conducted by dermatologists, and this is a red flag I'm raising. Laser treatment should be under medical supervision. It is not okay to have the tattoo artist to use the lasers to remove tattoos. The skin has to be examined well by a dermatologist in order to diagnose any early signs of melanoma. If that doesn't happen, then the laser treatment is going to be carried on without any determination of the early signs of melanoma, and then the patient will develop the melanoma later on when it's too late. It is going to be diagnosed. So this is something we have to be very careful with, very thorough examination of the patients before touching them with lasers is a must. A sunscreen with a high SPF has to be used during the whole treatment period and for 3 to 6 months after end of the treatment. This is really very important, and when we are using sunscreens, there are 3 important conditions which I always insist on. Number 1, the SPF has to be 30 and above. Number 2, it has to be applied every 2 to 3 hours, because after 2 to 3 hours it's gone, regardless how much the SPF is. Number 3, it has to be used indoors if the patient is staying in daylight lamps. Fluorescent lamps and daylight lamps are emitting ultraviolet, and it warrants sun protection. Bleaching cream may help, or serum of course, may help to get better and faster effects of getting rid of the pigmentation. Sessions are repeated on the same previously treated area every 6 to 8 weeks in order to give enough time to the macrophages to get rid of the fragmented pigmentation, as we mentioned earlier. What we do sometimes when we are not sure how the pigmented lesion will respond is to have a test area and then evaluate after 6 to 8 weeks, and when we have positive response, then we treat the whole lesion. So this is the sequence of events. Hypopigmentation is a common side effect occurring in about 50% of patients treated more than 5 to 7 times for tattoo removal. It is usually transient and resolves within 1 to 12 months. Some of the important pre-treatment precautions is the fact that any suspicious lesion has not to be treated except after taking a biopsy. As dermatologists, it's really very important to realize that complete surgical removal of atypical nevi is often recommended, especially if they undergo changes in appearance. And the giant pigmented hairy nevus is one of the lesions which can develop melanoma. So we have to be working in association with a plastic surgeon in order to plan the treatment for that patient and avoid treating the patient while they might have developed melanoma already. Regarding the cosmetic tattoos, we have to be careful because sometimes the patients are having multiple tattoos with skin color, like this patient, and when we try to treat the tattoo, it's going to uncover the areas of the previous tattoos, and it is going to lead to very bad cosmetic outcome. So it's very important to be careful what we are doing with the cosmetic tattoos. This is another patient who had a lip line tattoo, and after the laser treatment, it became lighter, which is not very good looking. So always I recommend to do test area, test spots on part of the tattoo before treating the whole tattoo. So in summary, nevus of Otta and nevus of Ito, those are dermal pigmentation. We use the Q-switch and the egg because of the depth of penetration, and this has to be followed by good skin care afterwards. The PIH and the melasma, I don't recommend using lasers. I prefer using microdermabrasion plus bleaching agent and sun protection. At least if it is not going to improve, it's not going to become darker. For freckles, solar lentigens, we use the Q-switched 532, the long pulse lasers and light sources. Sun protection is essential to prevent the recurrence. Regarding cafe au lait macules, the same, but we have to let the patient know that the recurrence occurs in more than 95% of cases. Regarding the tattoos, in general, we can use the Q-switched lasers, but test areas are recommended, whereas in cosmetic tattoos, the same lasers are indicated. However, test areas are mandatory to avoid the darkening or the oxidation of the ink with different color outcome. And for melanocytic nevi, it is not advisable. However, if there is no history of change within the previous 8 months, then the Q-switched lasers might be the best scenario. There were some trials to improve the outcome of the Q-switched lasers, like using different Q-switched lasers or wavelengths in the same session, using the Q-switched lasers with diascopy, the R20 method, the Q-switched laser and fractional erbium-YAG, the picosecond lasers, and finally the fractional Q-switched lasers. When we have multiple color tattoo like this one, black, violet, light blue, and yellow, definitely the 1064 is going to be required, but it's going to be targeting only the dark colors like the black. And for the other colors, we might need other types of wavelengths or the other types of laser. We are going to use the 1064 and it's going to show us the end point which we expect. With the other colors, which we might target the violet and the yellow color, like the KTP, the 532, we can see this endpoint. And then this is the after the 5th treatment in 6 months time, and this is after 10 sessions, but this took 2 years, so the patient has to know that the treatment is prolonged. However, when we are using multiple colors or multiple wavelengths in the same day in order to target the multiple colors, then we can get very nice clearance of the tattoos, even if it is multicolor. Another thing which we can do for the pigmented lesions when we have compound pigmentation and green toning is some sort of rejuvenation targeting the photo damage, that is chromia, where we are doing 2 passes, one with the 1064 with very low fluence, 2 joule, with 8 millimeter spot and 8 hertz. And then we do a second pass with the 532, also with very low fluence, 0.2, 0.3 joule per centimeter square with 8 millimeter with 8 hertz. And this is going to target both the dermal and the epidermal pigmentation. And this is indicated for melasma, for vascular melasma, and for dermo-epidermal pigmented lesions, which are more resistant. And this is a case of melasma, which shows very nice clearance after 2 treatment. Of course, topical bleaching agents and sunscreen were used in order to achieve this kind of clearance and to maintain it, because we know there is no cure for melasma. Once melasma, always melasma. So even if we use laser, it's very important to let the patient know that there is recurrence, and in order to avoid or delay the recurrence, it's very important to use very good skincare products and sunscreen to maintain the improvement. And this is the same patient, and we can see after 3 sessions how much her melasma and hyperpigmentation improved. The diascopy is a procedure which we do in order to decrease the skin reaction or make it more mild, because when we are using this glass light to compress the skin, then we are getting rid of the oxyhemoglobin, and only the pigment or the ink is going to be in the skin. And this makes also the pigment more accessible to the laser pulses, and this improves the outcome and decreases the downtime associated with the procedure. So this is something which we can do, where I use this glass slide as cooling. I put it in the freezer and I get it just before the laser session. I apply it on the skin and I fire the laser over the glass slide, and in this case we get much better result with much milder skin reaction because of the elimination of the oxyhemoglobin from the equation. The R20 method is a method which was introduced by Rox Anderson and his team about 6-7 years ago, where during one visit, 4 passes of laser is applied on the skin, separated by 20 minutes for clearance of the frosting effect. But the problem is that this is a too long session and it's too painful, and that's why it did not fly. It didn't prove to be more effective than doing 1 session only. What is really working, and I think it is a genius idea, is the combination of the fractional erbium YAG with the Q-switched Nd:YAG laser, because when we are using the fractional erbium YAG, we are creating channels through which the pigment can slough, whether it is melanin or ink. So we are adding to the lymphatic drainage pathway, which is the classical pathway to get rid of the pigments from the skin, another pathway which is sloughing through the epidermis, transcutaneous sloughing of the pigment. So this is showing that on the side which was treated, the combination treatment, the Q-switched Nd:YAG and the fractional erbium, only 2 sessions revealed this kind of improvement, whereas on the other side, 3 sessions revealed much less quality of improvement of the tattoo with the monotherapy. And this is another case where we can see the cosmetic tattoo of the eyebrow, and 3 months after 1 session, it is gone with the combination of the Q-switched Nd:YAG and the erbium YAG. Now we go to the latest advancement in the technology and in the laser world, which is the Pico technology, where picosecond lasers were used in order to fragment the pigments in a much better way much more effective way. However, now we have about 15 different units. The problems still are the price, where the price is a bit expensive. Stability of those systems is not very good, and the power is very low. The initial machines introduced were having very low power, so in order to get 6 joule per centimeter square, we had to use only 2 millimeter spot size. And if we go to 4 millimeter spot size, in order to have deeper penetration, the maximum fluence was 1.5, 1.6, which is very low in order to be effective. Now there were some improvements, and some of the devices are having both the Q-switched and the picosecond lasers, but this was an initial downfall of the picosecond lasers. Very old studies conducted in 1998 and 1996 didn't show a significant difference between the picosecond and the nanosecond lasers. So over the years, maybe the technology improved, but definitely the marketing improved better. Now, what I really like in the Pico lasers and the fractional Q-switched lasers is having this fractional hand pieces, where we are able to have certain lenses. With the lenses put in the pathway of the laser, whether it's Q-switched or picosecond, is going to focus the beam of the laser. So we are having high fluence, and this is going to create some sort of ablation, but non-thermal, because when we are using those kind of lasers, it is not associated with heat. It is a mechanical effect. So the first step is going to have some sort of channels and opening the channels to ablate. And then we are having the second pass with the Q-switched laser to fragment further the pigments. And in this case, we are enhancing the clearance, and a certain amount of the pigment is already removed with the first pass without a shield effect. We can see that this is associated with some bleeding, and then in 3 months after one treatment, the improvement is significant. Now, there are some possible side effects, like some of the tattoos are going to have some sort of allergic reaction, and we might have hemorrhagic bullous after the tattoo removal lasers. So this is something which needs just the proper skin care after that, and the reassurance of the patients. And this is something which happens usually with the red tattoos. So we have to be careful if we are treating someone who's having red tattoo, that this might happen, and we have to let the patient know from the beginning that this is a possible side effect. Also, scarring might happen if we use the wrong tool. So this is someone who tried to treat a patient with IPL, and they developed some scars, and then this is before the Q-switched lasers. And after 5 treatments, it's not easy, because when we are trying to treat scarred tissue, the lymphatic drainage is very poor, and that's why we expect that the treatment is not going to be as effective as we are treating healthy skin without scarring. Of course, hypo and hyperpigmentation might happen after the Q-switched lasers, as I mentioned before, and here the reassurance is the best way. Repigmentation will occur within 1 to 12 months, so sometimes it might take a year in order to have the repigmentation. We can have paradoxical darkening of the tattoo ink. The tattoo ink might be oxidized, and that's why it is really very important to do a small test before treating the whole lip or the whole eyebrow to avoid something like that. If it happens, we have to carry on and continue. It is just not easy to convince the patient after that to keep paying money in order to do something which we did for him. So the patient would see worsening, and then we are requiring him to pay money in order to let us improve what we did. It is not a very easy scenario. So by this, I end my presentation, and I would like to thank you all for your participation and your attendance today. And if you have any questions, I would be very happy to answer those questions. Dr. Rawan.
Hello, doctor. Thank you so much for a very interesting lecture. Maybe we'll just see if there's any questions before we move on to the next presentation.
Okay.
Actually, if I could start off the question, I actually have a question for you. So it was very interesting for me to hear, because we know that working with a lot of dermatologists across the region, that lasers are used not only for tattoo removal, but also for different forms of pigmentation, like what you mentioned, melasma and post-inflammatory. And in part of your lecture, you mentioned that you wouldn't necessarily recommend. Is it a certain type of laser that you would recommend to use, or would you not recommend at all?
Regarding melasma in particular?
Yes.
Yeah, okay. Melasma is a very big challenge. My reservation about using the lasers in melasma is the fact that melasma is not curable. So once melasma, always melasma. And this means that even if we are able to improve it with the methods I mentioned, like the green toning, where we are using low intensity lasers or whatever, it's going to come back one day. So on the other hand, if you are able to use good skincare products with good epidermal barrier repair, and good bleaching agents and good sunscreen, we might be able to get the same efficacy. So why should I go for a procedure which is costing the patient a lot of money for a condition which is going to come back? Now, I have to be clear, I have to be honest, and I have to explain to the patients that we can do laser, which is going to cost you X amount of money, and it is going to come back, or we can use a very good skincare regimen and it's going to control the melasma and it's going to achieve the same outcome. Some of the patients will require or will demand laser treatment, but after explaining to them all the options. So all what I'm saying is that I don't need to be aggressive with the laser treatment as we used to do 10, 15 years ago. We have to be very mild to avoid the complications. Number two, we have to explain to the patients all the facts about the treatment and the fact that this is not a curable condition. And then it is up to them if they would like to go for the appropriate skincare products or the laser treatment, which is going to be more expensive.
It's a very good point, very interesting point. I think there's another question coming from Dr. Shireen on your opinion on in Becker's and Nevus spilus. Is it worthy?
I think I covered the Becker's Nevus. I'm not sure if Dr. Shireen attended the presentation or no, but Becker's Nevus, as I said, if it is hairy, we do hair removal and it is becoming lighter. And then we discuss with the patients the further steps. If it is not hairy, then my recommendation is to try to convince the patient not to treat it because the treatment is going to be costly. The outcome is going to be very heterogeneous. Some areas will respond better than others. And in many cases, patients are not going to be very satisfied. If the patient insists on the treatment, then we don't treat the whole lesion. We treat segments. We agree with the patient which segment is the most important for them. And then we go on and keep treating this same segment every time the patient comes back till we reach the maximum clearance we are able to achieve. And if the patient is satisfied, then we go to another segment. This is the best way. And because this is a compound nevus, then we have to combine both the wavelengths, the wavelength which targets the dermal pigmentation and followed by the wavelength which targets the epidermal pigmentation. In the same session, 2 passes, 1 for each, and then we move ahead with the next treatment and so on. So this is regarding the Becker's nevus. When it comes to Nevus spilus, then again, we have to determine if this is epidermal, then we are going to be using the Q-switched 532, which is targeting the epidermal pigmentation. And usually in many cases, I prefer to do a test area because patients are having very high expectations. So it's important to treat part of the nevus, and according to the outcome, the patient will realize it is not only one session required and what is the kind of improvement we expect. This is much better than treating a whole nevus with charging the patient $400, $500, and then the patient is not satisfied.
Great, thank you. I think we have another question from Dr. Sahar. asking about the orange tattoo in eyebrows that are done in pore salons. What would be your recommendation?
Again, which eyebrow tattoo?
The orange eyebrow tattoo.
Yeah, orange eyebrow tattoo is difficult. Usually it is not easy, but for that we have to use the 532 wavelengths, Q switch at 532, and we have to let the patient know that sometimes after we do that, it is going to be oxidized, and instead of being orange, it might become gray or black. And in this case, we have to shift to another wavelength. So it's very important to let the patient know that we cannot control the reaction of those ink particles, and it might be oxidized, it might change the color, and it is much better to do a couple of pulses as test spot instead of treating the whole eyebrow and then ending up with a color which is totally unexpected.
Great. The next question is coming from Dr. Amjad, asking about the intraocular shield, and a continuation to the question. Also, if I'm going to use more than one spot size, should I start with a larger one, and for how many passes?
Now, the intraocular shields, it's a shield which we have to buy separately. It's not supplied with a laser machine. And then we have to sterilize it first, and then we have to use anesthetic eye drops, and then we have to apply it or put it inside the eye so that it protects the eye globe. We have to use the appropriate size to cover the sclera completely, and then we do the treatment, and then we remove it. It's very important to do it carefully so that we don't cause any corneal, abrasion or something like that. Now, regarding the spot size, I didn't understand the question, because usually we are going to determine the spot size according to the size of the lesion. The best scenario, if we have a large lesion, that we are going to be using the largest effective spot. So if I'm having a Becker's nevus, for example, this is large. So my interest is to use the largest spot size, which is 8 millimeter, for example. However, the 8 millimeter is having a maximum fluence, which it cannot exceed that fluence. So if the maximum fluence of the 8 millimeter spot is, let us say, 3 joule per centimeter square, but the 3 joule is not going to be clinically effective. I need 5 joules. So in this case, I have to use a smaller spot size, let us say 6, in order to be able to achieve the effective fluence. So I'm going to be using the largest effective spot size. And then if it is not working enough after the next session, because the ink is becoming less or the melanin is becoming less, then I have no option but to use a smaller spot size which can achieve the fluence, clinically effective fluence. I hope this answers the question, if I understood it well.
Great, thank you. And so Dr. Rania is actually asking, what is the best product that you recommend for pigmentation after laser?
This is a tough question. Actually, one of my favorite now is the topical tranexamic acid. And although we are on SKINCEUTICALS webinar, but I'm not really biased. It is one of the best products, the discoloration defense serum. I'm really able to use it twice per day. It is not causing irritation. It is not affected by the light exposure like the hydroquinone. I used to prescribe hydroquinone before, 4% once at night. However, now with the discoloration defense, I'm very much inclined to prescribe that for every single patient who is having any pigmented issue, as it is safe, it is effective, it's not causing irritation, and the compliance is very good, I can see.
Great, that's great to hear. From our side, of course, though, we love to hear the feedback from our clinicians who are using this every day and really see the results on the patients. The next question actually coming from Dr. Yasmin, asking about pre-orbital pigmentation. Can we use Q-switch laser to improve it, especially if there's an extension to lateral cheeks?
Yeah, actually, the periorbital hyperpigmentation is a tough topic. The dark halos or dark circles around the eye. Before we tackle that topic, it's very important to know that there are many reasons for dark circles around the eye. One of them is the sagging of the skin laxity and wrinkles, where the optical penetration is not going to be very good. The light reflection is not good. So if we just stretch the skin is not having pigmentation. So this is one scenario which is very common. The other scenario is that sometimes if we stretch the skin, we are going to see that there is no pigmentation, but there are some blood vessels below the eye, and those are giving the impression of dark circles around the eye. So those are two conditions where there is no pigmentation. When there is really pigmentation, then Q-switched laser has been promoted to be one of the solutions. I never found that this is a successful solution. In many cases, I had patients coming from other clinics with post-inflammatory hyperpigmentation. This is genetic, and I don't think this is going to improve with lasers. What we can do is to use good skincare products in order to lighten the skin. Oral tranexamic acid is going to help a little bit, but we have to limit the expectations. We have to let the patients know that there are some genetic issues which we are unable to improve. Patients with dark skin are having dark areas of certain areas of the skin, like around the eye, like around the nails, like the sensitive areas in the skin. This is the normal color of the skin, and however we try to treat that, it is not going to be treated, and sometimes we'll get complications. So we have to know our limits. This is my message.
Great. So I think maybe we can take the last couple of questions before we move on to the next presentation, if we can. From Dr. Wajih, after how many test sessions for tattoos of lips and eyebrows can we predict side effects?
Actually, one session is enough. We do one session, we evaluate it after 6 to 8 weeks, and if everything is going well, we go ahead with the treatment. That's it. We don't need to do more than one session of test.
Okay, great. And finally, from Dr. Mediam, in case of tattoo granuloma, as you know, we can't use Q-switch laser. So how do you recommend us to treat?
Actually, this is something which was brought up in a study where if that happens, if a severe allergic reaction happens after tattoo removal with a Q-switched laser, then we have no option but to try to remove the tattoo with an ablative CO2 laser. We know that it's going to leave a scar, but we need to remove the causative agent. If the foreign body granuloma happens in the lymph nodes, then maybe intralesional steroid injection might be a solution. So those are the two scenarios. If we do a Q-switched laser and then we have severe allergic reaction, then if the topical steroids and intralesional steroid did not help, then we have to ablate it. We have to try to remove it with ablative laser, but we have to let the patient know that there will be scarring. For the foreign body granuloma in the regional lymph nodes, then intralesional steroid injection might be the only solution.
Great. Thank you so much, Dr. Ashraf, and thank you for answering all of the questions. I apologize if we weren't able to get through all of the questions. I know it was a very interesting talk, and I'm sure there's a lot more questions to come. If you'd like, if you continue the questions on the chat, maybe I can gather them together and send them to Dr. Ashraf. We can maybe answer, and we can send all the answers out to you doctors in the future. But to wrap up, if I can just hold your attention for just a few minutes longer, and we wanted to speak to you a little bit about the solutions from SKINCEUTICALS for your hyperpigmentation patients, especially post-laser and post-procedure, which is one of the topics that I think Dr. Ashraf touched on a lot, is that the in-clinic procedures are extremely important for our patients, but at the same time, having a good home care regimen as well is very important to have good skin.
Just going before going ahead, Dr. Rawan,
Sure.
would that broadcast be saved on the YouTube or something?
Usually for the lectures, we don't publicize it on public forums.
Okay.
Usually this is dedicated for physicians only. We are recording the session for internal purposes, and if any of our physicians would like to have it shared with them.
Excellent. So, I mean, if you can just announce that at the end, because some of the colleagues might like to come back to the lecture or whatever, then it would be great.
For sure. So just to be clear, we are recording the session to be able to send it to all of the physicians joining us today, to have it if they would like to review it later. If they would like to review it, maybe reach out to Dr. Ashraf for any questions. However, we don't publish on public forums to keep it as a scientific community kind of lecture.
Great. Thank you.
Great. So if you just give me 1 second, I'll just share my screen. I'm just going to go through a short, brief presentation about the SKINCEUTICALS approach to hyperpigmentation. As we discussed in today's lecture, hyperpigmentation is not an easy condition to treat, and along with the very important in-clinic procedures that are done to treat the cases of hyperpigmentation, we would like to share with you some of the home care solutions that SKINCEUTICALS can provide for your patients to complement these in-clinic procedures. Now, at SKINCEUTICALS, we are firm believers in the prevent, correct, and protect philosophy when building any at-home skincare routine. Preventing future damage with our strong antioxidant portfolio, correcting the damage that has already been done with targeted treatments, and protecting healthy skin with our sun care range. Now, as we know, the role of UV radiation and other environmental aggressors play a big role in the pigmentation pathway, inducing inflammation and therefore triggering the overactivity of this pathway. To prevent this, the role of antioxidants has become very important. This actually has been studied extensively by Dr. SHELDON, the creator of SKINCEUTICALS, who actually dedicated 30 years of research to this field in particular. This is why today we are known as the antioxidant authority. With over 40 clinical studies and over 25 international dermatological publications, we have a strong antioxidant portfolio formulated specifically to cater to different types of skin and different skin concerns. Dr. SHELDON was actually one of the first dermatologists to start the research of the use of vitamin C on the skin. He started his research studying the role of environmental aggressors on skin in relation to skin cancer, and developed it further from there to extend to the role in photoaging and, of course, pigmentation. We know that vitamin C is one of the most potent antioxidants to fight these aggressors. However, by nature, it is also an unstable molecule. And Dr. Pinnell was actually the first dermatologist to discover how to get vitamin C to penetrate into the skin with the correct formulation. In his research, he developed what we refer to today as the Duke parameters, which is the gold standard of how to formulate the vitamin C serum under the correct conditions to properly penetrate the skin and give its benefits. The patented parameters developed by Dr. Pinnell cover 3 pillars. The purest form, having the purest form of vitamin C, which is L-ascorbic acid, with the optimal concentrations between 10 and 20%. Actually, if you go higher than 20%, the penetration actually starts to decline, and under the right pH. So since vitamin C is acidic by nature, the L-ascorbic acid should be in a formula with a pH of under 3.5. Of course, all SKINCEUTICALS antioxidants are formulated within these parameters, ensuring that your patients get the best quality and the most effective formulas. Dr. Pinnell and his team actually spent years research formulating different antioxidant formulations to cater to different skin concerns. Also, during their research, they focused on other antioxidants to combine with the vitamin C to enhance the efficacy and give superior environmental protection. So, since today we covered the topic of the role of in-clinic treatments, specifically focusing on lasers, we wanted to share with you the SKINCEUTICALS integrated skincare approach. And I think this is in line with really what Professor Ashraf was saying, is that the link of in-clinic to a good home care, skincare routine is very important. So one of the main roles of home care therapies is actually to enhance what is being done by dermatologists in the clinic. And this is why we believe so strongly in the integrated skincare pathway, from priming the skin before the procedure to the procedure itself, to having a home care routine of recovery. One of the things that Professor Ashraf mentioned was the skin barrier recovery kind of treatments, and of course to have a long-term enhancement kind of therapy to improve what is being done in the clinics and to further treat the pigmentation. Now, for laser treatments in particular, we've done actually extensive research on the role of using antioxidants directly post-procedure to enhance the healing process. So I know that what Dr. Ashraf mentioned, that maybe we don't use lasers on hyperpigmentation patients as often anymore. We do use lasers for other kinds of treatments, and even some hyperpigmentation patients who opt for this laser treatment. So we know that actually vitamin C has a role in wound healing. However, it has been the CE Ferrolique has been formulated in a way that there will be no irritation post-laser. We know that with some vitamin C serums, it can cause some burning, some stinging sensations because the skin is raw. However, using a alcohol-free, paraben-free formulation, as in the CE Ferrolique, it has been tested actually extensively to be safe and effective post both ablative and non-ablative fractional laser. CE Ferrolique actually is one of our top antioxidant serums with years of research behind it, with 15% L-ascorbic acid formulated at the optimal pH and purity, 1% vitamin